Hi, everyone, and welcome to the Family Matters interview series. Thank you for choosing to join the presentation, and we are so happy to have you here with us tonight. A few reminders that all lines will be muted throughout the presentation tonight. So if you have any questions, you can enter them into the chat box, and a member of the BCAT team will respond to you in 2 to 3 business days. We are pleased to have Heather Suri joining us tonight to answer the question, how do you know when it is time for assisted living? Heather Suri is a registered nurse with over 20 years of experience in community-based nursing and a credentialed care manager. Her work experience in skilled nursing facilities, home health, home care, outpatient settings, and hospice have prepared her for helping families navigate the options and resources for aging well and managing healthcare crises. Heather is the president of the Mid-Atlantic chapter of the Aging Life Care Association and leads her colleagues across 5 states and the District of Columbia. She guest lectures at area universities and is a Medical Reserve Corps volunteer in Loudoun County. Joining Heather is Lynn Young, the Director of Strategic Integration at Mansbach Health Tools. Lynn and Heather, I will turn it over to you.
Welcome to our Family Matters series interview this evening. Today we are joined by Heather Suri. She will be our topic expert and sharing all of her expertise and insights about how do you know when it's time to look for some type of residential placement or assisted living for your loved one. In this segment, we'll be talking a little bit about the role of the care manager and all of the services and expertise that they can bring to family members in helping you along this process of making these types of decisions. So as I said, welcome Heather Suri today. Heather, thanks so much for taking the time to join us. We really appreciate you.
Thank you for inviting me, Lynn.
Absolutely. Can you share a little bit about yourself and about what you do with our families tonight?
Absolutely. So I am an aging life care manager. I'm also a registered nurse. Care managers nationally tend to run about half of us are nurses, about half of us are social workers, and then we're seeing more and more people come into the field with a variety of other health and human services backgrounds. So I own a practice called Pathways in Aging, and I serve the Northern Virginia region. And me and my team members, other care managers and assistant care managers, help families navigate difficult diagnoses, navigate the healthcare system, build teams, coordinate care, and we have a whole lot of fun doing it.
Awesome. Sounds like you have a lot of services available to help support family members and help them on this journey. Can you tell us a little bit about how you get connected to families? What does that referral process look like?
Sure. So families come to me all different ways. They might be referred by their physician. They might be referred by a home care or home health company. Or sometimes they've just heard about care managers, maybe from a friend or a neighbor or somebody in their support group who has used a care manager. So most folks just call me, or I also, on my website, my email address is there, or people can schedule a consultation with me directly from my website. So there's different access points to find me. I'm happy to say that I think the word is getting out about aging life care managers. We used to be the best kept secret in healthcare, I think, but I think more and more families are starting to discover what we can do and how we can help.
Oh, absolutely. And once they've reached out to you, tell us a little bit about your process. How do you connect with them and how do you decide what they need?
Sure. So usually 2 ways. Sometimes I hear from people who are in a crisis. Maybe they have been hospitalized, or maybe their loved one has recently been transferred to a skilled nursing facility and they're trying to figure out what comes next. So in those cases, we just jump right in and we gather as much information as we can, and we start working with the other healthcare professionals that are involved and start helping the family craft a plan that has that elder or that person who's experiencing the health crisis in the center of the plan. When things are not in crisis, our preferred way is to go out to the home and do a comprehensive assessment. So we are looking at, of course, all of their health and medical needs, their doctors, their prescriptions. We're also looking at their functional status, how they perform their activities of daily living and their instrumental activities of daily living. We're looking at legal things, financial things. We're looking at nutrition. We're looking at cognition. We're looking at behavioral health. So we gather all of this great assessment data in a home visit, and then compile a very detailed list of recommendations. Some of those families take those recommendations in a formal report, and they just kind of start working on the things that they feel like are accessible or most important. Most of the families continue to work with us after that in implementing some of those recommendations to help move a care plan forward.
Okay, that sounds like a pretty comprehensive approach. It looks like you're looking at a lot of information and really trying to pull together strengths and weaknesses, needs, and what might make the most sense for each individual. You mentioned part of your assessment process is looking at their cognitive functioning. And I know you utilize the BCAT test system. Can you tell us a little bit about what parts of the BCAT test system you find most helpful and how you use that cognitive information and where that fits in to your overall plan?
Absolutely. So I really kind of put it in two different buckets. I do like to do the BCAT long form on just about every elder that I work with, to get a baseline of where they are. And I think that's particularly important even when there is not a cognitive diagnosis, because so often when elders have a medical event and they're in the emergency room, we see providers, ER docs, look at their age and assume they have dementia. And so if I have someone who does not have a dementia diagnosis and they're maybe having some mental status changes that are very acute, I like to have a baseline just to say, this is where we are. So what's happening here, we need to medically clear this first. So that helps to have that baseline data. But particularly for people who have an MCI, a mild cognitive impairment diagnosis, or have already been diagnosed with dementia, I really use the full battery of the BCAT assessment tools. I always start with the BADS, to look at the anxiety and depression, because we know that for older adults, anxiety and depression are often underdiagnosed and undertreated. And when those conditions and symptoms are present, they can mimic some cognitive symptoms that may or may not, kind of reflect where they are cognitively. So that's an important variable that we like to consider. I love the BCAT long form because it really helps me hone in to different aspects of their cognition and really start to understand their strengths and weaknesses. I think that when we assess cognition, we really tend to focus on the impairment and not on the strength. And we all know that, dementia doesn't, especially in the early and mid stages, doesn't universally impair all parts of cognition the same way. So if we can really start to understand the areas where they're strong and when they're weak, then we can put in interventions to support their weakness, but also develop a care plan that really plays to their strengths and helps to engage them in their own care as much as possible. When we look at the kitchen picture test and the verbal test of practical judgment, those are really helpful in a home setting to understand safety. And when we get these questions from families about, how much care do we need? Do we need to start bringing in home care? Can we leave our loved one unattended? It's often, unless there's been a crisis or something really bad has happened, that can be a really gray and fuzzy area for families about how much help is needed, how much supervision is needed. And so, that really helps me to understand how safe someone is, and helps me to make recommendations to the family about how much supervision might be needed.
I really like how you talked about mood, right? Anxiety and depression is, you're looking at the whole person. You're looking at their mood, you're looking at their judgment skills, you're looking at their cognitive skills. It sounds like you're kind of putting together these puzzle pieces that paint a picture about, where each individual is. And I like the strengths, the part where you mentioned you're focusing on their strengths and trying to maximize those and take advantage of areas that are really strong to help people stay as independent as possible.
Yes. And, there's so many, I'll tell you a quick story about the red chair. So one of the things that I love about the BCAT is that there is a section of that long form test that looks at kind of visuospatial abilities. And sometimes we have folks with dementia who start to have trouble with that aspect of their cognition. And so I had somebody that I was working with who dining room, wood floor dining room, wood table, wooden kitchen chairs. And she was having trouble getting seated at the dining room chair and was needing hands-on assistance to get seated safely in her dining room chair. And so when I was kind of looking at her BCAT and noticing a really significant weakness in that area, I know that color contrast can sometimes help people with visuospatial deficits. And so I convinced the spouse to paint one of the chairs red. We painted the chair bright red. And
that was a risk, right?
It was a risk because it really could have gone the other way. The person with dementia could have said, "This does not belong here. This is not my chair." But it worked. And, she was able to, it really kind of stood out from the background of all of the wood. And she was able to get down in her chair without having that hands-on physical assistance, which helped her to feel more independent, to feel less dependent. And so I don't know if I hadn't had that assessment result and hadn't kind of picked up on, is there something, should we look into this a little bit deeper? It just really kind of helped me come up with a creative intervention that was effective in this case.
I love that story. And I love the example because it really shows how looking at each individual, everybody's needs are unique, right? Everybody has different strengths and weaknesses and different needs. And that really aligned with taking what you know about her cognitive skills and connecting them to something meaningful and helpful for both the client and the family member. What an excellent example. Thank you for sharing that. I have another question. So I know I'm sure a lot of your clients are very interested in staying in their home setting, right? They want to stay where they're familiar, where they're comfortable. That's a comforting place, being in your home. But I also know that sometimes physical impairments, we've talked a little bit about cognitive impairments, may create a barrier to being able to do just that. What happens, or how do you handle those conversations with family members when you, as the professional, start to recognize that staying at home, into the future may not be the safest option or the best option if needs have changed or skills have changed? How do you introduce those ideas, and then what? How do you have the conversation with the families?
Yeah. So when we look at where care should be delivered and look at home-based care versus care in a residential setting, I'm usually looking at kind of 5 different buckets. So first, the care needs, for sure. What their functional status is, how much assistance are they needing? And sometimes when we look at assistance, especially for somebody with impaired cognition, It might not be physical assistance. Maybe somebody can still take a shower independently and wash their own body. Maybe they can get back and forth to the toilet. But if there is a dementia diagnosis, they may need a lot of verbal cues to perform each one of those steps, and a lot of kind of redirection and helping someone to keep on task. So care needs is the first thing I look at. I also look at social interaction. As we know, it's kind of coming back to that cognitive piece. It's probably the number one thing, and the kind of the easiest thing that we can do to help support someone's cognition is to make sure that they have lots of opportunities for social interaction. And so certainly people tend to become more isolated at home, especially if either cognitive issues are there or physical disability is there that makes it more difficult for them to go out independently. And sometimes even when we have a caregiver in the home, it's one person, or if it's even a spouse, it's one person. There's not as many opportunities for robust social interaction. So that could be a consideration for a residential setting. Finances are a big one. As someone's level of care or need for 24-hour supervision increases, the cost of care increases dramatically. And so sometimes there's a tipping point there when we look at the big financial picture. Is this sustainable over the long term? When we have someone with a dementia diagnosis, I'm usually an advocate of maybe making that move sooner than later, so they have an opportunity to develop routines and to form relationships with staff. And we want to make sure that we have really good planning so that we're minimizing the number of moves that need to happen. So what can we do to get them into the right place where they can age in place there, hopefully through end of life, so that we're not moving people. So the financial piece, the family caregiver, or whoever the primary caregiver is, if it's a spouse or if it's an adult child, we need to give honestly as much consideration to their needs as we do the elder who needs care. Caregiver burnout.
It's a big decision, right, for the families?
Well, it's a big thing, but it's one that is often overlooked. I work with so many primary caregiver spouses, both husbands and wives, who ignore their own health needs, their rest, their stress, their social needs, their everything, because they're caring for somebody who is dependent. And then we see that individual's physical and mental health start to suffer, as well as their collective finances become depleted. And so that's something that I really spend a lot of time talking with families about, that it's, elders don't age in a vacuum. It's something that that affects everybody else in the family. And so we really have to look at the situation holistically. If there's a caregiving spouse who is becoming emotionally or physically depleted through increased caregiving needs, what can we do to protect them so that they can remain an advocate for their loved one? It's difficult to be an advocate when you're exhausted or when your physical health is not good. So I really try to frame it for, this loved one needs you to be healthy and strong. And if that means that we need to put you in, more of an advocate role and let the hands-on physical part of caregiving be done by someone else in a different setting, then sometimes that is the right choice for families. And then cognition, is a big one, especially in choosing the right place and the right time. But like we talked about before, even if some of those activities of daily living, if someone still has a level of independence with those, that need for supervision, for redirection, sometimes in a setting that is very structured and very routine oriented, and is really set up to accommodate someone with impaired cognition, sometimes they actually do better in that setting than they do at home when it's not as structured.
Wow, thank you for all that information. That's a really great overview of sort of the big 5 things to be mindful of or considerate of when you start to make these kinds of life decisions for a loved one. There are a lot of choices out there, right, for families. And I know there's lots of different types of settings, right? We hear about independent living, assisted living, nursing homes or skilled nursing facilities, even places that are memory care centers, or some buildings have memory care components built into them. Can you tell us a little bit about the differences between those and how you guide families to look at all of their choices and really find just the right fit for them?
Yeah, and I'm so glad you asked, Lynn, because there's so many kind of misconceptions about those different levels of care. Some people think that everything is a nursing home. And that's something I get often. So, when we look at kind of the least restrictive level of care is independent living, which is essentially almost like an apartment, like a regular apartment. But those buildings often have dining options, they have housekeeping, they have some things that sometimes they have transportation to social or recreational events or medical appointments, and they often have some kind of activities program. So there's, social things to do to get people together, but there is no care in those settings. So some people choose independent living, knowing that they can bring in the care they need. They can bring in private duty home care and kind of layer that in when they need it. Maybe they have more choices about who they use and when they use. And if someone doesn't need a lot of care, then it can be a more affordable way to go. But there's no nurse to call in those.
It's a good way to remember it.
Yep.
So that's independent living, right?
That's independent living.
You have your own apartment, but you have all the amenities of having connections to others, dining, all these other supports.
Yeah,
Okay.
those instrumental, I say those IADL supports. In assisted living, you have an apartment, but you also have a nurse, a director of nursing there in the building, might be an LPN, might be an RN. You will also have a caregiving staff who is available in the building. So in an assisted living setting, which may be appropriate for someone with dementia, or it may not, depending on where they are in their disease process and also the building itself. But there will be an individualized plan of care that will be developed for that person. And that plan of care is reevaluated periodically to see what needs to change. But there would be somebody who would be available to help hands-on with a shower, help hands-on with toileting, help somebody get in and out of a wheelchair, in addition to the dining, the social programming, all of those things. And most of the places, especially I'm most familiar with Northern Virginia, but most places have physicians who will act as primary care providers who will come to the building. So that really is helpful when it gets difficult to get out and see a doctor. A lot of times your doctor or your nurse practitioner is just a phone call away and they'll come and see you there. And that in and of itself can sometimes be a reason to look into it, because as folks age, we all know we've got a lot of medications happening and we have multiple medical specialists, and getting out to all of those appointments can be really difficult. So really bringing that medical home in can be really beneficial. We also look at memory care as being kind of an extension of assisted living, and there are some memory care communities that are all memory care. There's nobody in the building that doesn't have a cognitive impairment diagnosis. And then there are other buildings that have memory care separate in the same building, but separate programming. The primary things when we're looking, I think probably 2 things when we're looking at appropriateness for memory care. One is the individual a wanderer? Do they need a secure unit in order to be safe? Because memory cares are secure, which means that you can't get out easily without a pass. So if we have someone who is what we would refer to as exit seeking, what I tell families are, if somebody's going to go out front and hail a cab,
right. Well, that's a concern.
Then the memory care might be kind of a safer and more appropriate choice. The other thing we see in memory care communities is usually a lower staff to resident ratio, which can be helpful if someone is needing a lot of verbal cues, a lot of redirection, a lot of that type of interaction, having programming that allows kind of the time. So an example would be, it's a lot faster as a caregiver to put someone in the shower and wash them and move on to the next person than it is to work with someone and say, okay, now let's wash your arms and let them do it. But that's an important part of having somebody stay engaged in their care. So we want to
keep their independence, right?
Yeah.
We want them to do everything they can for themselves as long as they can.
So we want those kinds of staffing ratios that supports that model of care. And so sometimes that is better in a memory care community. Most people will not be in a nursing home. That's something a lot of people think everybody ends up in a nursing home, which is certainly not the case. So, a nursing home is appropriate for a slice of the demographic, particularly if they have care needs that can't safely be delivered in any other place than has 24-hour nurses available. But most people could stay in assisted living or memory care through end of life. And often I think the experience in those settings may often be better than it is in a nursing home, just because of the staff ratios. And a nursing home is a more clinical environment, where an assisted living has a medical model, but it's a more social environment than it is a clinical environment.
That's a good way to think about it. Thank you. Yeah. Wow, thank you for that really detailed overview. I think that's really helpful to kind of look at all the options that are out there. And it's good to know that people may start in one place, and it's okay to look at or consider other options as you age or as your needs change. There may be other places out there that are a better fit as you go through, whatever disease process or life changes, occur. It's good to know that there's so many options out there. We're almost out of time, but I wanted to definitely ask you, how do folks reach out to you? How do they connect to you? Tell us a little bit about how to find you.
Sure. So I think the easiest way to get in touch with me, if you're in Northern Virginia and you want to talk about how care management might help your family, you can find me on my website, which is www.pathwaysinaging.com. Or you can Google me, Heather Suri, S-U-R-I, and you'll find me and my company. The other thing I wanted to share, because I know that you will have viewers joining from all over the country, if you go to aginglifecare.org, you can do a zip code search to find an aging life care manager in your area. The Aging Life Care Association is the professional association for care managers. It makes sure that we have the right level of education, the right level of experience and credentialing to do this work. And so you have a very good chance of finding somebody well qualified and really good using that zip code search. So I recommend that.
Great, thank you for that suggestion. It's nice to know that there's a credible source out there that can help direct people to high quality services that they need, even if they're not in your immediate geography, but they can find that no matter where they're located. Well, we thank you so much for taking your time today to share all of your knowledge and expertise with us. We've learned a lot. It's been really helpful. And I really appreciate you taking the time to join us. Thank you so, so much. And any last parting words, any other thoughts for families before we end today?
I just want to share with the families out there that there are a lot of right ways to do things. If you're watching this program right now, you're probably feeling some pressure about making the right choice. And there's lots of right choices. So, you know, you're doing your research, keep doing that, keep talking to people, you know, access a professional if you can. It will make this journey easier.
Great advice. Thank you so much, Heather Suri. Take care.
Take care. Thank you.
Thank you.
Thank you so much, Lynn and Heather. That was a great presentation. We would like to take this opportunity to invite you to become a member of the Enrich Brain Health Program by signing up on our Enrich website. And if you're interested in more information from the BCAT Research Center, you can follow us on Facebook, Instagram, Twitter, or LinkedIn. And those links are up there on the screen for you now. If you have any questions, go ahead and type them into the chat box, and a member of the BCAT team will respond to you in 2 to 3 business days. Thank you guys so much for joining this episode of the Family Matters series, and we hope to see you again for our next episode in November, entitled, "When is it time to stop driving? Guidance on how best to handle a very difficult situation." I'll stay in the meeting for a few more minutes in case anybody has any questions. And otherwise, I hope you all have a great night.